Everyone, can we get your attention, please? How's everyone doing? Bright and early? Welcome to All School Day 2013. We want to welcome you. My name is Christian Diaz. I'm the student org president for this year.
And I'm Elisa Zambrano, the vice president.
So we want to give a shout out to who's here. Let's see, do we have Orange County in the house? Woo! How about Scribble?
How about San Diego? What about BAC?
UPC? So let's get a quick chant to wake you all up. So when I say fight, you say on. Ready? Fight! Fight! When I say fight, you say on. Fight! Fight! There you go. So we're going to do a little giveaway to begin. We're going to give out shirts. So put your hands up, see who gets them. Ready? So I just want to give an introduction to our moderator for today. Her name is Cherry Short. She is the Assistant Dean of Global and Community Initiatives, has made a career of fighting for equal rights and social justice. After sitting on the United Kingdom's National Committee for Race and Inequality, she was appointed Race and Equality Commissioner for Wales. Additionally, Short served as a city councillor and in 2006 received the Commander of the British Empire Award. Domestically, Short is involved in local community projects, including the Family First Committee for Jordan Downs, and continues her work as a forensic social worker. So we would like to introduce Cherry Short.
Everyone, a great morning we're going to have. Thank you, Kristen and Alicia. Good morning to you all. I'm so pleased to see so many of you here today to discuss and learn about this really important topic. And I'd like to welcome all our virtual academic students who are joining us today via webcam. As Kristen and Alicia have stated, I am the chair of the All School Day Committee, and we're looking forward to yet another great morning of our All School Day. I'd like to thank the committee for their help in planning today, and I'd like to also thank former chairs and previous committee member of the All School Day, because without their hard work, this event would not have continued. All School Day, as we all know, is an educational forum born out of the 1992 civil unrest and has become our school annual event, recognizing diversity through an exchange of ideas. This year, All School Day will be looking at healthcare inequality, otherwise known as Does Health Equals Wealth? We know that the health of individual people and their communities are affected by a wide range of contributory factors. People's good or bad health is often determined by their environment and their situation, their genetics, their income, their educational levels, their relationship with others, and of course their race, all related to good or bad health. The Institute of Medicine 2008 report study shows that the higher a person's social economic status, the more likely he or she is able to enjoy good health. As social workers, we already know many of these facts. If your water is clean and safe, the air you breathe is pure, your workplace is healthy, your house is comfortable and safe, then you're more likely to experience good health. In March 2010, President Obama signed the Patient Protection and Affordable Care Act. Under this new law, 95% of all Americans will be insured. What are those implications? Some people believe that it is not government's responsibility to guarantee health care coverage for all Americans. Some would also say that guaranteeing all health care will decrease the quality and availability of health care throughout the US. Some would say, too, that everyone has a right to health care, regardless of income or status. Whatever your position is on this matter, you'll be able to voice your opinions today and ask questions of our speakers. And as Dean Flynn stated in the most recent USC Chronicle, the Patient Protection and Affordable Act will have implications for all social workers. Today we have some great speakers, as I've stated, and our keynote speaker is Dr. Winston Wong, Medical Director of Community Benefit, Kaiser Permanente. We also have our panelists, who I'll introduce later in the program. It is now my great pleasure to introduce to you, and of course, we all know Dean Flynn very well, but I would like to introduce her, however. Dean Flynn is beginning her fourth term as Dean of Social Work here at USC and be one of our school's longest-serving leaders. During her tenure here, she has expanded international programs, introduced the military social work specialization, developed one of the country's most active social work research centers, quadrupled the size of our full-time faculty, and launched our academic centers at Skirball, Orange County, and Santiago. She opened the Virtual Academic Center, the first truly national web-based program in a prestigious research institution by a high-ranking school. As a result, our school has now surpassed the 3,000 mark in enrollment. Can you believe that? How wonderful that is for us. Of well-qualified students who will build a new future in our profession. This year, Dean Flynn received the International Sarnat Prize from the National Association of Social Work. And this spring will receive the University of Southern California Award for Education Innovation from President Nakias. Welcome, Dean Flynn.
Well, it's truly wonderful to see all of you here because I'm not sure if you realize it, but this is the only time we all meet together as a group. All of the campuses, the faculty, many of our staff, it's the first time I used to say it's the first time we can all see each other face to face, but actually that's not true anymore since we have such a large and active group of virtual academic students. At any rate, it's the first time we can all hear each other at the same time. So I hope you'll take advantage of this opportunity to engage in this extremely important topic that we've selected. This event started as a result of the disturbances in 1992 that affected a 37-block area around USC. And it depends on your point of view, but known as the civil disturbances. There was widespread antagonism, destruction of property, considerable misunderstanding between community groups. And as a result of that, the faculty voted to make this an official class day. We vary. One year it counts as a field day, the next year it counts as a class day. But the point is really to come back to the question of disparities and diversity. Initially, we used to focus on just those matters that most affected us here in the Los Angeles community, and especially in the neighborhood where this campus is located, the UPC campus is located. But now that we have a national scope for our school, we're trying to pick themes that everybody would recognize, no matter what community they live in. The issue of health disparities is something that is a universal problem, no matter whether you live in a rural area, an urban area, a highly diverse community, or a relatively homogeneous community. It affects everybody. It is a main issue for us as social workers, and because we are now a mighty force across the country, our understanding of this problem and our ability to intervene is especially important. So I'd like to introduce at this particular time Dr. Winston Wong. I'm really pleased that he was able to come together because he is an exceptionally distinguished and at the same time highly involved both locally and nationally in the issue of disparities and health quality. At the present time, he's the medical director of the community benefit section of Kaiser Permanente. Probably everybody here knows what Kaiser Permanente is, but I'll mention that it is the nation's largest nonprofit healthcare provider. It has 9 million members and 15,000 physicians. Dr. Wong's responsible for developing community partnerships, and he also develops studies of health outcomes for groups that have been identified, targeted groups such as diabetics. He develops metrics, he studies these groups, and is especially interested in the whole area of evidence-based medicine. And as you know, we have a high emphasis in this school on evidence-based practice. He's concerned in developing an emphasis on the elimination of health disparities through the practice of evidence-based medicine and better understanding of health outcomes. At the present time, he serves on a number of national advisory committees, but I want to mention in particular his presence on the Institute of Medicine Committee on Integration of Primary Care and Public Health. I'm not sure that all of you know what the Institute of Medicine is, but it is a group, a highly prestigious group. It is one of the most prestigious groups in the country, which regularly considers health policy. He also works with the Asian community in the practice of medicine and maintains a small family practice right now as Asian Medical Health Director. Dr. Wong is a graduate of UC Berkeley in ethnic studies. He also earned his master's and medical degree from UC Berkeley and their joint program with UC San Francisco. He completed his residency training in Seattle at Providence Medical Center. He's a native of San Francisco. He's a dragon boat racer. And this part is the only part of his life that I'm struggling with. He's an avid San Francisco Giants season ticket holder. So Dr. Wong, would you please come to the podium?
Okay, forgive me for being a fan of the world champion Giants. But it's just amazing to be here with you today and be part of this, I think, family gathering. It's very special. It's a beautiful auditorium, a beautiful morning in sunny Los Angeles. So it's a great honor to be here with you and have some fun with you and have some discussion around some really serious issues. Now, I was in the audience and had a chance to meet Dean Flynn and Dean Short. Provost Vega is a colleague of mine that I've been able to work with in the last several years. And I kind of reflected, I said, I don't think I've been with a group of deans and provosts, so many of them since, you know, basically I was protesting at Cal. I'm not used to having conversations with deans and provosts. I'm used to having the protest sign, you know, down with something, up with something. So it's really good to be with some friendly academicians and administrators of a great school of social work. It sounds tremendous, the work that all of you are doing and what you're aspiring to do for our communities. So one of the things, too, is I appreciate the opportunity to come to Los Angeles. You know, part of Los Angeles and going around the country to talk to various groups is I actually learn a lot by looking at the evening news. And so yesterday, you know, what was the evening news yesterday in Los Angeles? It was about Baldwin Hills. Like, we have a collapsing road in Baldwin Hills. I don't know if you heard that this morning. And they spent about 10 or 15 minutes in the evening news and the morning news about Baldwin Hills and a collapsing road. And then another 15 minutes on the Lakers won 3 in a row, and Kobe, you know, Kobe is actually a team player. I said, wow, that's pretty interesting. Now, so, you know, I'm a native San Franciscan, and what have we been talking about on our news? And swear to God, what do we talk about in our news in San Francisco? We're talking about the right to be naked in front of people. I don't know if you've been following that. We have this group of naked citizens that feel it's their right to be able to march around naked throughout the city. As long as you don't do it in a lewd way, that's what they say. It's hard to figure that one out. And then the other thing is, oh, by the way, we are spending a lot of time for our news talking about the super-bound 49ers. So you see, we have our priorities straight. Now, this is a raucous crowd. And I was thinking, you know, Dean Flynn, Provost Vega were saying, it's a lot of people, several hundred people, thousands of people. And I was thinking, well, that's as big as the USC marching band. So it's not too intimidating in that way. Now, the other thing I learned was, okay, I'm convinced that my hotel room was designed by a woman architect. Why do you say that? Because I had this really interesting experience with my bathroom yesterday night. And it's basically a bathroom that does not allow a toilet seat to be put up. It's like, you know, you put it up and it falls down. And I was thinking, okay, maybe this is too much to share. But, you know, it's like Jay Leno. I have to tell you, it's the male pirouette, because I have to have my feet shoulder width apart. I have to go like this to hold the toilet seat up. And I'll let you figure out what the right hand does. But all right. Okay. Too much. You know, my kids would probably say, "Dad, that's really bad." Okay. Back to business. Well, a couple of things. One was, so Bill called me up and he said, you know, Winston, I want to have you talk about health disparities, healthcare reform, social determinants of health, where the future is in terms of the context of social work, medicine, health, and do it in 20 minutes. So it's pretty big. And then, he follows up with a call, and he says, and tell us what you think about Beyonce lip syncing and Michelle's bangs and who's going to win the Super Bowl. So, my answer is to those last three questions, bad, good, and who, Niners. So that give me 5 more minutes there. But this, I think this whole issue of your conference today with regards to does wealth mean better health? And as you look at your program, poor George Washington has Band-Aids on his forehead, which I think is very clever. Now, you actually have to think of 1 trillion of these George Washingtons. And dare say, it is not a scrape on the head. The 1 trillion headache is a migraine headache for our country. It is recurrent, and it is unrelenting, and it is a crisis in which we face with regards to the disparities that we see in healthcare. And so the question was, does wealth mean better health? Now, it's very interesting that if I asked you today, if you had a really serious illness, like a brain tumor, what country would you want to be in to receive health care? Canada, someone said. I actually think most of us would say we would want to be in the United States. Now, today, one of the front page news stories is about a quadruple amputee who served in our armed forces and has been transplanted 2 arms. That is a miracle of American medicine. And if you think about if your loved one or yourself had a brain tumor, I would argue I'd rather be at USC School of Medicine than anywhere else, because we are at the cutting edge of medicine. Now, when you ask, does wealth mean health, then you also have to look at where is the United States relative to this place where it's the wealthiest place on earth. And if you stack up all the countries from A to Z, number 30 is where the United States is on most public health indicators, such as infant mortality. So there's countries like Croatia, for all places, that have higher or lower infant death rates than we do. So there is some sort of disparity that looks us right in the face with regards to living in a country that has great institutions of health care and medical care, places that I would put my loved one in. And then we have instances in communities where disparities are stark, where the infant mortality rate among African Americans is 2 to 3 times of the index population in the United States, and that the African American infant mortality rate is comparable to many developing countries across the country. Why do we have such a wide disparity? And how do we think about the challenges in terms of healthcare reform? Now, I was going to show you some slides today, but as you can see, we don't have a screen. But I did want to show you, what would these slides show? And the first few slides is, we have inequities in health in terms of prevalence. So if you look at diabetes, the percent of adults over 18 with diagnosed diabetes among Hispanics, Latinos, 23%. Among African Americans, 22%. Among Native Americans, it's 33%. Among Caucasians, it's 11%. If we look at adults with high blood pressure, Hispanic, Latino, 63% of adults, Latino, with high blood pressure. 57% among African Americans, 51% among Caucasians. These are stark reminders that we have disparities. There's a disproportionate burden of disease. Disproportionate burden of disease among communities of color. Now, if it's just a question of prevalence, maybe it becomes a simpler story. But we have disparities in terms of how people receive care, and get access to care. So if you look at things like heart failure, hospital admissions, the admission rate for African Americans is more than 3 times higher than Caucasians for heart failure. That suggests that something is wrong not only with the prevalence, but the fact that a certain group of people have to go into the hospital much more frequently than other groups of people because of a treatable condition. You find that with regards to diabetes and asthma. So not only are we seeing a disproportionate burden of disease and prevalence, we have a disproportionate burden of people who are receiving suboptimal care that correlates very strongly with poverty and race and ethnicity. Now, if that's 2/3 of the story, the other third is we have a disproportionate burden with regards to people who have access to care. Access to care. So if you look at the folks that are uninsured, it is disproportionately people, Latino, Asian American, African American. These are the folks that don't have regular sources of care, who are largely the uninsured in America. And as we're celebrating, to some extent, the onset of healthcare reform, it falls somewhat short of what we aspire to be. Now, I can give you all those facts and figures, but I have to tell you, as Dean Flynn mentioned, I'm still a practicing family practice doctor. And part of the reason I still see patients is I need to always learn and remember what our patients face every day. And I have a very short story. So I saw a patient last year, about the second or third time, 52-year-old Chinese woman who only speaks Cantonese. I saw her for lower back pain. I'm a good diagnostician, I think. So I looked at her back, see if there's any neurologic impairment, any problems with strength. Basically, I thought muscle spasm associated with overuse. And I said, well, I'm going to put you on ibuprofen, a nonsteroidal anti-inflammatory agent. Let's have you come back. I want you to take these medications on a regular basis every 4 to 6 hours with food. Don't stress your back. Come back and see me in 2 months. Comes back and sees me in 2 months, and the Chinese woman says to me in Cantonese, Dr. Wong, you're a great doc. I like you, but your medication didn't help me that much. It helped a little, took the edge off, but the back pain's still there. And I said, well, why do you say that? I mean, maybe I should do something more. She says, I know why the back pain's there. I said, well, you know why the back pain's there. Why don't you just tell me? Back pain is there because every day I go through the waste baskets around the neighborhood looking for plastic bottles. So I stoop every day, hundreds of times, to gather the plastic bottles and put them in the bag in which I go to the recycling center. I think we have all seen our fellow citizens who do this. So I said, well, Mrs. Lee, how much do you make a day doing this? $10? And she said to me, Dr. Wong, I'm lucky if I make $5 a day picking up plastic bottles every day. So the disparities issue is encapsulated in those kinds of stories. In terms of a woman who has back pain, who's been in the United States, who's uninsured, but the roots of that are related to poverty. And as much as I try to be the greatest doc in the world, it is not answering the question. So we have to come to that reality and figure out this whole constellation of issues. Now, that story really reminds us, why do really people get sick, after all? Okay? And if you think about it, when your loved one in your family gets sick, it's the first thing you said, that person got sick because they didn't have health insurance. Most of us would say it was part of the equation. In fact, there was some smart person who figured out how much can we attribute to the kinds of things that shape health, factors that shape health. Personal behaviors, through some sort of algorithm, account for 40% of why we have bad health, or configure our ultimate health. Environmental and social factors, 20%. And genetics, family history, another 30%. And you know, by the way, the medical system shapes only about 10% of how our ultimate health outcomes would be. So how can we spend so much money on the 10% at the part where we're sick or injured? So I wanted to go around all of you today and say, look in your wallet. You might have $10 there. Can you give me $2? Because that's how much, basically, about 18% of every American dollar is going into healthcare right now. Or alternatively, you can figure it out. I got $100 in my back pocket right now. I got to have 120. Somehow our healthcare system was configured in its most optimal way. Not maybe 120, but you wouldn't have $20 less than what you currently have. This is a confounding issue for our country and our economic and our security, as people have said. So let's explore this issue with regards to disparities. Now, I mentioned then all these factors related to disparities. We see disparities because there's differences in the quality of care received within the healthcare system. There are real differences. And I come from Kaiser Permanente, and I can tell you, we have 100% insured people, and I will be, with all candor, tell you that we are not achieving across the board, when you break down for race and ethnicity, the same kind of outcomes we want to see equivalent across the different groups. We are developing strategies to address that directly, but we don't see the elimination of disparities within Kaiser Permanente. By the way, how many of you are Kaiser Permanente members? Offhand, raise your hand. Thank you for supporting me to be here today. We have differences in access to health care, as I mentioned. And we have differences in the life opportunities, the exposures, as Dean Short was saying, and the stresses that result in differences in underlying health status. And I'm going to explore what that means a little bit later in my talk. Access, quality of care, and what we understand as the determinants of health. Now, I'm starting to get away from this term determinants because I think that's too deterministic. That there are factors that influence the behaviors we adopt, the environment in which we live, but they're not necessarily determinate depending on the social context in which people are involved in every day. So let's look at healthcare reform. Now, I wanted to ask you all, where were you on March 22nd, 2010? Do you remember what you did on March 22nd, 2010? Okay. All right. Because I have to tell you, reviewing, I'm too much of a policy wonk right now because on March 22nd, 2010, I was actually in Washington, D.C., in a hotel room watching Nancy Pelosi count the votes down to secure health care reform. That is a memory etched in my brain now with regards to how significant that event was. And you are living through a time where we're going to see the most profound changes in social policy, health policy, in a generation, since certainly Medicare. March 22nd, 2010. And it was magical to see each congressman saying, yay, yay, yay. And then occasionally you get this nay from a certain group. But March 22nd, 2010. Now, the other thing that I remember now is well, I should ask you, what were you doing on June 28th, 2012, a little bit closer to today? June 28th, 2012, what was I doing? What were you doing? At about 7:20 in the morning, Pacific time. So this is why I'm really like, God, hard to relate to now. I was on a treadmill. And the announcement was made, and it was really interesting. It was from the Supreme Court with regards to their verdict on the constitutionality of the Affordable Care Act. And I'm running there with headphones. I go, yay! and most of these people in the sports clubs are not into health policy like me. So it's like, but it's very interesting because on June 28th, 2012, the very first pieces of news that came out suggested that the Supreme Court was going to rule that the Affordable Care Act was unconstitutional because the individual mandate was not declared constitutional by the Supreme Court, which was true. But as you know, it came down that the Supreme Court Chair, Justice Roberts, said it's not an individual mandate, it's a tax. It's a tax. So we do have the Affordable Care Act. Now, some of you may think the Affordable Care Act starts on January 1st, 2014. It does not. The Affordable Care Act started happening as early as October 2010. And I think some of you were affected by that because there were provisions in the Affordable Care Act that said, number one, if you had a pre-existing condition, you could not be denied health care coverage. That already happened. Number two, pertinent to my family, if you were a child or if you had a guardian, parent that had a health insurance and you did not have health insurance, you could still be covered under your guardian or parent's health insurance up to age 26. So these provisions have already kicked in, as well as being the medical expense ratio, where health plans have to expend at least 85% of the money they collect to actual medical coverage. So there are pieces of the Affordable Care Act that already have been enacted. Now everyone, though, is focused on what happens January 1st, 2014. And what does happen? The question is, how do you insure 37 million Americans who haven't been insured in a generation? 37 million Americans. The way to think about that is if all of California was uninsured, how we're going to get coverage for these 37 million Americans that have not had coverage. There are two major pieces and one minor piece to expanding coverage. And this is your little bit of health policy wonkish part of the presentation. We're going to expand Medicaid from those that have an income level of the 0, as we say, federal poverty level, up to 138 of the federal poverty level. Now, it used to be for you to get Medi-Cal in California or Medicaid that you had to meet certain criteria. You had to be a mother. You had to have, to have it as a man. It's virtually impossible to be covered under Medi-Cal currently. You have to have certain conditions. Come January 1st, 2014, it's a question of income only. Income only. So every American citizen that falls below 138% of the federal poverty level can qualify for Medicaid. With the one provision that the Supreme Court said, you have to be in a state that's going to participate. And they let this opportunity for certain states to say, you know what, we don't want to be part of this grand plan. Okay. The other part to this is we're going to set up, and it's really interesting, something called the health insurance exchanges. Now, what are the health insurance exchanges? They're basically the Travelocity, the orbits of healthcare insurance. It's kind of a scary thought. But lo and behold, you as Californians, come January 1st, actually they're supposed to have it pretty much prepared, ready to go October this year. Scary thought. You're going to go web page. And you're going to compare health plans. And you're going to be able to purchase insurance. And if you see the premium saying, the premium for a person 25 years in, or let's say 30 years, individual person, how much does it cost? And it costs $700 a month. And you say, you know what, I only make $1,000 a month. Or maybe more like maybe $2,000 a month. Federal government is going to say, we're going to give you a break. You're going to be able to purchase on those purchase the health plans with a subsidized assistance from the federal government. The orbits of healthcare. Okay, so it is a whole new world in terms of what's going to happen. That's how we think about expansion to 37 million newly insured Americans. Now, let me ask you, and actually this is a good crowd to ask because you think about it all the time, what is the federal poverty level? And yell it out now. $13,000 for an individual? Is that? No. Well, no, not quite. So, family of 4, okay. Well, family of 4, it's about $27,000 right now, federal poverty level, okay. And if you go up to 400% of the federal poverty level, you're going to be up to about $97,000 or $100,000. Those folks falling in between the gap, between 133% of the federal poverty level and up to 400% are going to have some level of federal assistance. So that's kind of the grand plan, master plan. Did I already confuse you? Well, okay, average Joe American's even going to be more confused. Average Joe American who doesn't speak English is going to be even more confused. Average Joe American who doesn't have as much access to the internet is going to be confused. We're entering a whole new world. Now, on top of that, as I like to say, people who are going to get coverage, they don't statically remain covered under Medicaid or Medi-Cal, and they don't statically remain within the health insurance exchanges to get subsidies, because people have changing lives. They might be employed now by a company like Target, get health insurance, then they might get laid off. They get laid off, they might qualify for Medicaid. Or they get a part-time job at a restaurant, they make more money than they qualify for Medicaid, but they can purchase on the exchanges. It's going to be a very fluid situation, as opposed to now, when you're basically uninsured or insured. And if you're uninsured, you might get Medicaid if you fall under certain population criteria, like being a woman with kids, etc. It's a whole new world. Now, how do I think of how healthcare reform is going to roll out? So I was thinking about the analogy. And I was thinking, you know how you go on YouTube and you say, hey, I want to check out that YouTube, right? And you click that button, it starts downloading and it starts going, and then all of a sudden it freezes. And you go, how long do I have to wait for this thing to fully load up? And then it goes for another 10 seconds and it stops. And then you wait another 2 minutes for another 10 seconds. It's kind of like the drug pusher strategy, you know, keep you engaged. But I do think that's going to happen with regards to healthcare reform. We have a great grand plan. And by the way, it was a Republican-derived plan. It was not a Democratic-derived plan in terms of setting up these marketplaces, as we're calling them. It started in Massachusetts, for God's sake. Something that, you know, Governor Romney wanted to always forget. But these marketplaces and Medicaid expansion are the basis in which we think about covering 37 million Americans that were previously uninsured. And it's going to be a YouTube stuttering kind of process. Now let me ask you, come January 1st, 2014, is our world going to change in terms of the disparities that I talked about? Is the world going to change in terms of the burden of diabetes? Is the world going to change in terms of the infant mortality rates that we see intolerable among communities of color? Is the world going to change that the patient that I saw is going to have a different set of circumstances? You know, because you work with this population, the world is not going to change. The world is going to be a little bit better, a little bit more just with regards to being health care as a right. Of course, 7 to 11 million folks that we live with every day are not part of this, not part of the calculus. Those undocumented individuals that live side by side, that work in our communities, are not covered under health care reform. But having said that, coverage is not the only part of the equation. Because as I mentioned, it's 10% of what ultimately means with regards to our health status. what are the other parts? The 40, the 60, the 70% that's associated with behavioral changes, associated with environmental conditions, our family history. If you look at the major diseases that cause us early death, cardiovascular disease, heart attacks, cancer, chronic respiratory disease, diabetes, think about why do people have these bad diseases? Unhealthy diet, inactivity, tobacco, harmful use of alcohol. At least a great majority of those individuals with those conditions are associated with that. So do we blame the individual based upon these behaviors? In fact, if you look at the causes and behaviors that shape health, as I mentioned, tobacco represents 20% of the actual causes of death in the United States. Poor diet, physical inactivity, 14 to 15%. We're not talking about things like drug overdose. We're not talking about wrong medications. These are the things that are at the core of really what causes the chronic disease and the bad health that we see. So we have to think about all these elements in terms of achieving what we aspire to as a healthier America, healthier citizens. And this is where we started to talk about the social determinants of health. What are the social determinants of health? If medical coverage is only 10% of the solution, we're talking about things like education. People who have higher educational attainment have better health. People who have access to fresh foods and healthy behaviors, walking, parks, are likely to have better health. So much of the configuration of folks like Bill Vega is thinking about the community interventions that need to take place that go way upstream before you ever see the doctor, ever anyone like me. I have how much longer? Oh, that's fine. Okay. Because let's talk about the giants. But anyway, we need to really address what are those social determinants. Now, I said, though, I'm getting away from this term of determinants. Because if I said to you, every person that lives in a certain zip code is going to have a bad health outcome, you might agree with me. In fact, the California Endowment, which is the biggest health philanthropy in the country, has this big sign is your zip code will tell you more about a person's health status than their genetic code. Where you live is going to give you a better sense of where ultimately your health outcome is going to be rather than your genetic code. But we all know individuals, people in our own families, in our extended family, that come from poor neighborhoods, that come from destitute backgrounds, that are able to make a better life for themselves. And they're able to really have fairly good outcomes, despite all these issues with regards to lack of access, lack of coverage, and the environmental factors that impact their health. Am I denying those aspects of social determinants of health? Far from it. And this is where I'm thinking. There was a study at Kaiser Permanente in 1997, which was known as the Adverse Childhood Events Study. Has anyone heard about that? Okay. So those of you that have heard about it, make sure that I'm telling the story correctly. We actually looked at tens of thousands of patients in the Kaiser Permanente system. These are all insured folks, and largely more or less middle income. And when we looked at, and the story goes that the physician who was in charge of this was looking at his obesity clinic, and he looked at people who would go well in terms of losing weight and then would drop back and gain weight again. And he asked the question of, well, what is the cause of why we see progress and then people drop back? Did a survey comprised of dozens of questions with regards to individuals' backgrounds. And what they found was that events that happen throughout a person's childhood impact behavior and how people manifest disease. Now think about it. This is a middle-income insured population. And we asked things like, as a child, did you have recurrent and severe physical abuse? Did you have severe emotional abuse? Did you ever have any contact sexual abuse? Not just, floating bad pictures, but actually having physical contact. Did you have a household with an alcoholic or drug user? Did you have a household that had an individual that was mentally ill or chronically depressed? Did you have witness a mother being treated violently? Questions like this that you can imagine are associated with really bad emotional trauma that kids witness. So this is, again, a middle-income group of patients. And it was very remarkable that what we did is any one of these events that you would have been exposed to, not like the total number of events, but any one of these particular descriptions of kind of adverse childhood experience, we'd give you 1 point. Compared to people that had 0 points, those that had been exposed to 4 of these adverse childhood experiences were more than twice as likely to be smokers. 12 times more likely to have attempted suicide. Twice as more likely to be alcoholic. And 10 times more likely to have injected street drugs. So when we mention this study, most people say, well, duh. And when we see people in our clinical things, our clinical encounters, and we see people that have these behaviors that we know is going to associate it with poor health outcomes, the underlying question is whether they were exposed to adverse childhood events. And this is a middle income. Now, I theorize that in vulnerable communities, the exposure is even more so than in middle income insured populations. And the question then is not so much about the institutions that surround different communities, whether you have a park, whether you have a supermarket, whether you have a good school, is the protection mechanism, the social interactions, and the critical question of resiliency among those individuals, particularly children, that have exposure to adverse childhood events. And when you think about people who smoke, who use drugs, who exhibit violent behavior, it's not so much a question that they are anomalies or that they're bad people that adopt bad habits. Smoking, alcohol use is a therapy for many individuals with regards to numbing, anesthetizing the pain that occurred throughout their lifetime. Those communities that have less resources, less social assets to provide the resiliency, to provide a safe haven, to disrupt the influence of adverse childhood events, to decrease the amount of adverse childhood events, those are our most vulnerable communities. And as we take a hard look in taking on social determinants, it's not just a question of investing in schools and investing in parks, fresh foods, all critical features. And this is where you come centrally into the question. It's about how do we create the social communities and the social network to disrupt this cycle of individuals who are disproportionately emotionally traumatized, socially traumatized, in a way that leads to a bad trajectory towards health. Health insurance will be part of it, but it is not going to be the end of it. So I think about these things as, again, relative to my clinical practice. And I saw another lady who had hyperthyroid disease. She told me, she's like 36 years old, in Chinese again. I had to stop my thyroid medication because I got laid off. I'm at the last week. Actually, didn't even say that. I haven't been with my thyroid medication to keep my thyroid under control for 2 months. And, you know, she lives in a household where she's the single mother. The question is not what January 1st, 2014 will bring us in terms of the opportunity for that woman to be covered, but the opportunity for all of us, myself as a clinician, you as part of the healthcare team, all of us as terms of community citizens, to really think long and hard about this fact that we have coverage now for perhaps 95% of Americans, and get to the roots of how we disrupt this cycle of disparities. And how do you really configure the solutions that are not just institutional, but around the social capital that we build. So I hope we have a really great conversation about these things throughout the morning. Thank you very much.
Okay, everyone, that was so good. We so thank you, Dr. Wong, for putting everything in context for us, and we truly appreciate it. And we'd like to thank Bill, Dr. Vega here, for actually bringing you. So thank you all. Thank you. Right, now more excitement. We'd like to open the floor for questions from the audience. So please, the microphones are here. We also have a number of our VAC students currently here and some of them listening in, so we're looking to have questions from them too. So please, people who want to ask questions, now's your time to actually get onto the podium. And I'm looking also at the balcony, so feel free to use the mic as well. Okay. So it's good just to stand in front of the mic. That would be a good place to be. All right. Okay, if you just say your name and then say the question that you currently have. That'd be fine.
Hi, my name is Nicole. And when we're talking about the healthcare coverage, is this going to include therapy and other psychological advances like therapy and counseling?
That's a great question. So I'll have to give you a fairly detailed answer. So actually, several years ago, the individual that really pushed for this was Rosalyn Carter. And Dr. David Satcher, Surgeon General, who made it illegal for health plans to deny mental health services as part of coverage. So that is in existence, and the question is, in terms of expansion. Now, it's not mandated, but one of the configurations of the Affordable Care Act is these different approaches towards paying for value in terms of paying for outcomes. And you might have heard this term, accountable care organizations. You know, the idea is we want to give you a set number of dollars to care for people with diabetes or take care of someone with, COPD. Does that also entail costs related towards providing the social counseling, the care management, the social work, mental health support that people need to really recover from any of these issues? And I think health plans are going to be looking very seriously at how we take on behavioral support, mental health services as the total price that we have to configure with regards to caring for people with different issues. But it doesn't say per se we pay for social work. It really depends on payers understanding that social work and therapy is probably going to derive more value than continuing to send a doctor to see a physician.
Thank you.
Okay, next person.
Hi, my name is Martina.
I'm wondering if you think income inequality is part of the picture and whether raising incomes for especially the lowest earners would be positive, or if that hasn't been shown to be effective.
Well, I think the whole question of income and, of course, racial and ethnic disparities is closely related. So it's a complex issue because I'll tell you one thing. At Kaiser, as I mentioned, we look at disparities. And we looked at certain things like blood pressure control, and we compared how our lower quartile of low-income individuals compared to the highest income levels with regards to Kaiser Permanente members. And there really wasn't that much difference. The difference was much more profound in terms of ethnicity and race. So I'm not saying that income doesn't make a big difference. It's a big confounder. But I think there's a unique situation in the United States that being minority in the United States is part of the formula of having an unequal beginning with regards to your health. Now, it's also true that in the last 15, 20 years, that the disparities between low-income and high-income people, the gulf has widened and deepened greatly. And we see that in association with regards to deteriorating health and the onset of diabetes and obesity as being a predictor for overall health. Diabetes, people who are obese, much more likely to be among people who are low income.
Hi. The person on the balcony.
Hi. Anthony Sherbandi from the Virtual Academic Center would like to know, how can social workers effectively engage in the implementation of the Patient Protection and Care Act on the state-by-state level?
Well, that's a really good question. So I mentioned the orbits of healthcare. Actually, we're getting away from calling it exchanges. Sebelius herself said, kind of proclaimed, we're not talking about exchanges anymore, we're talking about marketplaces. And I'm a little bit ambivalent about that term. But I mentioned that because part of the Affordable Care Act includes this provision of patient navigators. And patient navigators in the first context means individuals who are in the community helping individuals who are not covered make the right choices for coverage. So that's one ideal place, I think, for social workers to understand where the communities are coming in and maybe be actively involved in being patient navigators. The other thing is with regards to how do social workers engage communities and individuals about being informed healthcare consumers. And I think this is really important because if the one way of looking at it is welcome to the market or welcome to healthcare right now in the United States, 37 million Americans newly insured. Welcome to this cesspool that we have. That's one way to look at it. I think there's a much more active role in terms of what are the issues that are meaningful to individuals who are low income in terms of the associations with regards to determinants of health and the things that will keep you healthy. So there's a lot to be activated in there, and there's some grants to be able to spread what healthcare teams really means, expand that definition to include social workers. Yeah, okay. Thank you.
As someone that's currently at the Veterans Administration Hospital in San Diego, I kind of work with a microcosm of universal care. And one of the main challenges we see is this population in terms of getting access to their initial primary care is getting access to an MD or nurse practitioner that might take up to 2 months or more. So along those lines, with the fact that we have so many people that have been generationally underinsured and have these generational health issues, what problems do you foresee in terms of the market demand of needing more primary care physicians such as MDs and nurse practitioners to be able to address these generational health care needs? And how might that have a spillover into the social services sector?
Wow, a great question as well. And one that certainly we could spend a whole symposium on, because it basically comes down to the fact is right now our capacity for caring for 37 million Americans newly insured and the pressures on primary care, there is a great mismatch. And not only that, the primary care providers that we currently have in place are not really well supported in terms of taking on new delivery models of including social workers, including care managers, including medical assistants, nurse assistants in the whole care management team. So as I mentioned it, the YouTube analogy, we're going to have to thing where everyone's expecting something and then we're going to stall because there's going to be some real pressures on the capacity of our healthcare system to really provide primary care optimally. I do think that what physicians have to do is to consider that they're navigating a team of professionals that has the patient at the center, and they don't have to make every decision, but they do need to have an overview of what things would be optimal for the patient. But folks that are not with medical degrees are going to play a great role in terms of configuring the constellation of services to maintain that person's health. But we have a lot of re-engineering to do with all our professional schools to get to this goal.
Thank you, Dr. Wong. Next person.
Hi, good morning. My name is Karen Jones from Orange County Academic Center. Knowing that we're going to have so many people come in on the rolls in January, how prepared are we as far as providers are concerned?
Well, you know, when you talk about providers, providers are heterogeneous. So I talk from Permanente, Kaiser Permanente. We have 16,000 physicians that are organized to provide specialty care, primary care, care management, chronic disease management. But if you look at the majority of healthcare physicians, providers in the community, 70% of the physicians are in practices of 5 or fewer physicians in a group. And I really worry about those physicians in small practices. And you see, and we can just go 1 block away from here, all the different, you know, physicians that have their shingle, so to speak, hanging. How well are they going to be able to deal with influx as well as these new demands with regards to validating the quality that they provide and taking care of panels and stuff? We are trying to accelerate the change of those practices in all of medical practice to deliver on quality rather than piece by piece. And the Centers for Medicare and Medicaid Services is trying to incentivize those things. But if you ask me how well prepared we are, it's the 4th quarter and we're 2 touchdowns behind.
Thank you. Oh, 1 moment. Sorry.
Hi. This question is from VAC student Therese Minder Almanza. She wants to know, what can we do as social workers to get the point across to the President and Congress that even though the Affordable Care Act was approved, insurance companies have increased the premiums for those with pre-existing conditions by 100 to 200%. A lot of people cannot afford this ridiculous increase. What can we do to get the government to crack down on insurance companies to control those high increases?
So, as I mentioned at the beginning, most of the time we communicate with the protest signs. No, I mean, I say that a little bit facetiously, but I do think that the voice of the public and public outcry needs to be part of the equation. Now, when you remember when Obama first came in the office, there was actually a fair amount of showcasing, if you will, with regards to him sitting down with health plans, sitting down with medical groups, organized medicine, sitting down with pharmaceutical companies. It is a stakeholder and power equation with regards to how we're going to move in this continuum. And I think social workers and the constituents you need to represent, you have to be organized as a voice too. And I think you have powerful arguments with regards to the correlation between the lack of social services and the ultimate outcomes of medicine. Because the question is going to be driven by healthcare dollars. How much do we spend on healthcare right now? About $2.7 trillion a year. So it is not like we don't have enough dollars in the system. It is about how dollars are allocated. So that's where you need to make your position.
Could I also ask people who want to ask a question, if they go to the podium now? If you don't go to the podium now, then I take it that you don't want to ask a question. Okay, next person.
Thank you. Good morning, Dr. Wong. I'm Paul Young. I'm actually a student here at UPC. I have more of a personal question. I just wanted to find out what event or series of events actually serves as the impetus behind the initiatives that you're developing. So initially, what actually prompted you to take this path?
Well, that's a good question too. And as I think Dean Flynn mentioned, I was an ethnic studies major and at Cal. and I protest it. So, no, it's about, I think, when you and me as an individual really understood what it would be to be a physician and what it would bring value to my life. It's a question of being immersed in terms of understanding the struggles that people really have to put up every day. And being at a community health center, caring for patients who are non-English speaking, and I'll say this too, having a father who was an illegal immigrant, how far can we go with regards to what's really important to us? And then we make the choices, and we're lucky, emphasize lucky, that we have opportunities. And people like us and Bill Vega who have some opportunity to make a voice for ourselves, we need to be able to exploit that for the causes of what we feel are important. So being a primary care doc, being from an immigrant family, and really trying to understand what it means to be a physician has brought me to the places that I've been able to go to, including USC. Thank you.
Okay, so we still got a few more questions. So if you could just make your questions a little bit shorter, that'd be wonderful. Thank you. Thank you. Next.
Good morning. I'm Ruka Suzuki from OCAC. But I was kind of wondering about how you feel that how insurances are going to judge what is considered a necessary procedure or a necessary, what they deem as necessary as in testing, and how that's going to be affected by this Affordable Care Act, and given that there's a growing amount of people who are going bankrupt due to costs from surgeries and scans and whatnot.
As mentioned earlier, I think one of the things is what is evidence-based medicine? And I'll give you an example. A certain drug or a certain medical equipment company is going to say, we have the next best and the most cutting-edge technology. You guys in the hospital, you should adopt this because you're going to pick up various diagnoses. That's never been confirmed. So there's a lot of issues with regards to why healthcare costs increases. It's because technology in America, which is at top of the class in the world, continually come up with a new gee whiz kind of thing that we in medicine get very seduced by. So now it comes to what is the evidence to support that these highfalutin, high-cost medications actually make a difference in equipment. And it is a political struggle with manufacturers, with regards to drug companies, and medicine itself to say, where is the evidence, not only in terms of individuals, but where is the evidence in terms of a population's health actually improving? And we do have some beginning institutions that are looking at that, including something called the Patient-Centered Oriented Research Institute, the PCORI, which is based out of Washington, D.C. and was funded by the Affordable Care Act.
Thank you.
Next person.
Good morning, Dr. Wong. My name is Nadia. So I had a question regarding the young adult population and the provision of the Health Care Act where parents are able to maintain their children up to age 26, I believe. So after graduating from college and entering my early 20s, I had my own difficulties paying for health care and paying my own medical bills, especially since it was very difficult to find a job. Now, luckily, I'm in the School of Social Work and I have the student health insurance, but I'm wondering if you think that the provision that parents can allow their children to stay on their health care will create any problems for parents that are paying their young adults, children, medical bills in the future.
Well, I think basically you're saying with regards to employers provided health care insurance, whether that puts pressure on the parents because they might have kids that are under 26 that might benefit from coverage. And I think the answer is we're not seeing that phenomenon. So at Kaiser Permanente, our membership actually increased by about 100,000 once that provision was put in place because all of these adult children are now covered. It's a good thing because people like you are basically healthy individuals, and healthy individuals contributing to the pool of a group of folks that have wide spectrum of disease is a good thing. And once you are over 26, even if you're not covered under your parents' health plan, either you're going to buy into the marketplace or you're going to be able to get employer-covered insurance. So overall, it is a good thing. It is not a good thing when people get discontinued around health care coverage. Everybody agrees on that, including health plans, including the government, including the most, conservative politician. It is not a good thing when people get disruption in their health care coverage.
Thank you.
How you doing? My name is Eugene Dworak. I'm also a School of Social Work student here at UPC. Actually, as I got closer to the mic, I started to forget my why I came up here. For one, I think one thing that stood out to me during your presentations, where you gave the percentage of the health indicators, whether it be personal behavior, medical insurance, and environment, and the different breakdown that you gave in terms of 20% being the social environment, one place. I think that the environment actually determines a huge predicament to your behavior. If you're surrounded by large amounts of fast food restaurants and there's not even Trader Joe's in your community to go to, I think you're more likely to have those different health outcomes that you described, such as diabetes and the others that you named. And one of the things I want to know was, what is Kaiser's plan to come into communities such as Compton and Watts and South LA that lack the appropriate health care facilities that are offered in the places such as Gardena and others. So what are your thoughts on that?
Short question. Okay. So it's undeniable that when communities have access to fresh food, parks, their environment is going to improve, and the conditions in which kids are able to thrive are going to improve tremendously. And to answer your second question, this is what Kaiser's been thinking about. So we've actually pooled in millions of dollars to set up what we call healthy eating, active living communities and coalition groups. We don't believe that Kaiser should set it up. We believe that the money should go to the community groups that are doing the work, that have credibility in those communities. Having said that, at Watts, for example, we have a Watts Education Center. It's a freestanding education center for kids that we just put money in just as a place for kids and community to get support. So I'm proud of Kaiser Permanente's investment in our communities, but it's more important about the social partnerships and the context in which these things really embed. The thing about putting supermarkets and stuff like that in place, it used to be the supermarkets were a bad thing, actually, because they would, big corporation coming in and making small businesses just go out of business. I don't think it's so much about certain things. I think it's about how our community interacts with those things and whether communities are empowered to do things. Now, I'll give you an example. If you go to Chinatown, maybe not in Monterey Park, I'm talking about San Francisco Chinatown, you don't see any supermarkets in San Francisco Chinatown. You see small businesses. But it's a thriving economy. It's because that community has empowered itself to set up its own businesses. I'd rather see the dollars actually circulate within the community than circulate outside of a community. So we can have Trader Joe's there, but where's Trader Joe's headquarters? So we have to deal with these issues around really getting communities empowered to be able to do what's right for their community. It's rather than think about things and think about social capital.
Okay, Dr. Wong, we just got a few more, and then that's all now. Please don't come to the podium. Thank you.
Hi, I'm Nora from Orange County also. And I'm thinking in our classes and as social workers, we're told, we make a difference. And when you're talking about health, social workers are more indirect or preventive. So when you think about social workers making a difference in health, to really get that more used, as a tool, it needs to be more billable. Because when you're looking at health, you're going to a doctor and you're sick now, and that's the way our financial structure and the infrastructure is set up. So if physicians could bill for social worker time rather than just their own time, then that might make more of a difference, but I don't see that in any of the plans and that kind of model, and I wondered what you thought about that.
Well, I think it's an excellent point, but I'll be honest with you. I think both professions need to mature. And what do I mean by that? Physicians don't know what social workers do, or they think about it in a very stereotypic way. I got this person that needs to go to a convalescent home, let the social worker deal with it. That's really a very immature understanding of the constellation of the services to support the different patients' need. At the same time, much of the social work community, we need to develop the metrics that associate your interventions with real evidence-based that shows that your intervention really changed the trajectory of the care outcome and the chronic disease that we see in communities. Maybe that work has been done. I'm not a social worker professor, obviously, but I think we need to push continually beyond the qualitative aspects of what your work entails into the quantitative metrics that make a case with regards to improved outcomes, because that's what the world is going to.
Good morning. I think you touched on this just now, because one of the things that really struck me during your talk was about how early childhood trauma and neglect results in later poor health outcomes, and that's something that we see a lot in our work. And that was my question, is how you see that integrating with some larger health initiative to actually take that into account.
Yeah, so that's what I'm trying to toy with right now. Is there something that I can do out of Kaiser Permanente as someone who weighs in on policy that not just takes the validity of the ACE study in consideration, but starts to design a potential intervention that we see as addresses the adverse childhood experiences and is associated with short-term, intermediate, and long-term events. So I think one of the things that's really interesting to me is young mothers or pregnant mothers, in utero, babies. Is there a way that we can preemptively strike with regards to the exposures that young child may or may not be exposed to, and create the structures around the family, the mother, so that we, number one, reduce the number of adverse childhood events, and number two, build up the institutions to provide resiliency to that family so that they can mitigate the influences of adverse childhood events. So I'd be more than willing to collaborate with Dean Flynn on this kind of thinking. This is where I think we need to go to get a much more preemptive and prevention orientation towards how we work with families.
Okay. Thank you very much.
And we're nearly finished now, so yeah. Okay.
So Erica Tanner from the VAC would like to know what, if any, implications are there to the Health Care Act with the upcoming revision of the DSM?
Oh, gee, you're really getting that's getting a little bit out of my league. What I've heard of the DSM, it's of course a wider spectrum of diagnoses that are making possible. I think the mental health and psychiatry world is dealing with, to what extent do we start to medicalize psychological conditions? And I think there is a drive overall to get to almost a molecular level to associate certain behaviors and psychiatric illness so that it can be covered under a medical diagnosis and thus be covered under a set of provisions in terms of medical interventions. I don't know if that's a good or bad thing, but I think that that's probably the implication.
Oh, thank you, Dr. Wong.
My name is Jackie, UPC campus, and I was just curious, and you can correct me if I'm wrong, but Kaiser currently does not accept Medi-Cal as a coverage. So I was wondering with the new health plan if Kaiser will be opening the doors to those who will still be covered under the Medi-Cal provision, which are, mostly the population of low socioeconomic status.
So actually, I have a very nice answer to that. Actually, Kaiser does have Medi-Cal members within Kaiser Permanente. It's about 325,000 now. And we have now 325,000 out of 9 million. You can figure out the fraction. But our plan is to greatly increase that proportion because we feel, as a healthcare plan, that we can't but accept and take care of Medicaid, Medi-Cal members as being part of our total family of members. And the fact is, how well we do with people who are covered under Medi-Cal and Medicaid is a forecaster, predictor of how well we do for everybody. So we're committed to doing that.
Am I missing somebody?
Yes,
oh, yes,
right
okay.
Promise. VAC student Christy Jensen would like to know, or has pointed out, that the process of getting on and being able to prove one's eligibility in order to stay on Medicaid or to get Medicaid is currently extremely complicated and frustrating, as I think we all know. Is there anything within the new healthcare policy that's going to make it easier or simpler, or is it going to be worse?
Well, that's a great question, too, and I'll tell you two things that I'm involved in. One is I'm on a CMS, Center for Medicare and Medicaid Services, task force or advisory committee on how we make better known what coverage is available to patients. So we're figuring out, recommending to the federal government more effective ways that they can reach out to potential recipients. The other thing I'm involved in is an Institute of Medicine Committee on Health Literacy. And part of the work there is around how do we communicate to people on the street what health coverage is really about. And I've been working with a professor at Emory, Ruth Parker, who's a leader in health literacy. We want to boil it down to 4 questions. What's the cover? How much does it cost? Why should I care? And how do I get into it? And if you talk to anyone, and you talk to your family members tonight, these are things that are shrouded in mystery. How much does it cost? How much will I have to pay for it? Where do I get it? What does it cover? And why should I care? But this is what we need to distill down so we can remove the opacity with regards to what it means to be an informed healthcare consumer in this country.
Thank you so much, Dr. Wong. Those of you who had questions and still thinking about it, we'll be able to ask them of the panel after you've had your short break. So there is a short break for 10 minutes. So please be prompt in coming back so that we can finish on time as much as we possibly can. So, okay.
If you would return to your seats, please, we would like to begin the panel.
Could we have people seated, please? Thank you. Okay. Everyone will have a chance to get together afterwards. Please be seated. Thank you. Okay, can you be as quickly as you possibly can? Thank you. Move on, please. Okay. Please find your seats. Thank you. All right. Thank you. Okay. I'm sure you'll agree that this morning was wonderful. Should we give another round of applause to Dr. Wong? Dr. Wong for president. Okay. Well, welcome back. Today, as you know, we are looking at inequalities in healthcare. It's my great pleasure now to introduce to you our panel. The first person I'd like to introduce to you is Professor William Vega, who is a provost professor and holds a USC appointment in social work, preventative medicine, psychiatry, and family medicine. An elected member of the Institute of Medicine, Professor Vega has conducted community and clinical research projects on health, mental health, and substance abuse throughout the United States and Latin America. Professor Vega will be speaking on health issues in the aging Latino community today. Secondly, I'd like to also introduce Dr. Rosalyn Morrell. Dr. Morrell is a radiologist, oncologist, graduated from the University of Arizona and completed her fellowship at the Mayo Clinic. She has been published in several distinguished peer-reviewed journals and regularly gives lectures that provide a unique and advanced perspective on cancer. Her latest article focuses on ethnic disparities in clinical trials. Dr. Morrell will be speaking on oncology and the treatment compliancy in minority population. And she's also the daughter of our dear June Wiley, which is here. The next person I have is Professor Hortensia Amaro, Dean Professor for Social Work and Preventative Medical and Associate Vice Provost for Community Research Initiative. Professor Amaro has over many years made landmark contribution to improving behavioral health care in community-based organization by launching addiction treatment programs and having helped thousands and informed practices in agencies worldwide. Professor Amaro will be speaking on her time in Boston, looking at public health and communities and some of those disparities in those communities. Thank you. Now, what we'll actually do is that we will ask each individual to speak for about 5 to 7 minutes about their work in the healthcare system. At the end of that presentation, we will again open the floor for questions from the audience and also from the VAC. So please get your questions ready and then we can start. Those who weren't able to ask their questions to Dr. Wong will be able to ask their questions to the panel. Okay. Dr. Vega?
Good morning. It's a pleasure to have this opportunity. I have to say that in 3 years that I've been here, this is the first chance I've had to actually be in the presence of basically the entire school, whether they are physically present or really virtually present. And I just want to say, I think for all of us this morning that our central purpose for being here is really to stir your passion for social justice and for the work that you'll be doing to try to overcome some of the worst aspects of social injustice. And it's in that arena that I'm going to be speaking to you today. more specifically about issues around wellness and aging and the ability to sustain people in communities and optimal functioning in low-income, vulnerable communities. And, of course, I'm going to focus a little bit on Latinos, but many of the things I'm going to be saying, I think, are really pertinent across the board. I think one of the things that I want to start with that I think is absolutely fascinating to me, and this moment exemplifies it for me. Winston was talking about his days at Berkeley, when he was at Berkeley and holding his signs and doing the things that motivated Berkeley students will do. And I know this about Winston because Winston and I served on a committee for years and had chances to talk about all of this stuff. And you know, I was also a student at Berkeley 20 years before Winston was there. I was a graduate student at Berkeley, and I was there in the roaring 60s when we actually went face-to-face with the police and the administration and everything else and got ethnic studies started. And I was one of the negotiators for the students, because I was one. I was a graduate student. I was advanced to candidacy. No, I don't think I was even advanced. I was just at the point of advancement to candidacy, I think. And I was one of the negotiators, and for giving us rooms in Dwinell when we started. You know, I think it's still there, in the basement. And we were getting our offices and fighting for more room, for more space, just the way Dean Flynn gets people coming and fighting for space here. And we were fighting for professors. You know, how many was everybody going to get, and how we were going to divide them up, and you know, all of that, right? And then, of course, once we did that, we had the battle of who's going to actually do this. Who's going to actually teach this? We're starting this in a few months, and who's going to actually do this? And so, again, you know, very bravely, I stepped into the breach and said, I'll teach one. And I remember walking into my first class there and wondering, what am I going to teach? I mean, it's a big responsibility to walk into a classroom and start teaching when you're just a graduate student yourself, and you want to get something going that has meaning, and you feel the obligation of it. But I bring this forward because the paradigm that we were working with then that we used to think about intellectually, this is Berkeley after all, you know, we were intellectual about it, we weren't just knocking walls down. It was also the issue of self-determination. You know, that was our fundamental premise, was self-determination, which I think became really the paradigm for the development of the College of Ethnic Studies at UC Berkeley. So you can imagine my happiness when I heard from Winston that, in fact, he had majored in ethnic studies. You know, 20 years later when he was there, he majored in ethnic studies and then went on to become a physician and went on to the things that he's doing now, which I believe, and I hope is true, and I want to believe it, I guess, because that those original seeds of social justice, self-determination for low-income communities are the same things that are driving his consciousness today as he goes out and works, you know, in this capacity of moving between Kaiser and community reinvigoration. So I just want to point that out, that these legacies, you know, these things, I'm not saying that I was responsible for him, because clearly I was not. Because, you know, but the bottom line is that I think things that we start have many kinds of consequences, and we don't necessarily see the long-range impacts of the things until many years later as they begin to play out in the arc of our lives, right? And so I'm glad I had a chance to actually intersect with somebody who was, in fact, went through that process and is now actively out there and has the opportunity to influence so many more people. And I think that's what all of you eventually are going to be doing, is having an opportunity to influence so many more people and move them in the direction where we can begin to resolve some of these issues that I'm going to be addressing this morning. So having said those things, I'm just going to try and hit on some highlights to open up your minds to these issues that we're going to be discussing at the end of our respective presentations. But I think I want to put one forward challenge to you right now to think about, because I think this is really what we're dealing with, and I thought that it was brought up in some of the questions, at least partially or wholly, at the end of Winston's presentation. And that is the question of how do we modify social determinants in society and increase social capital in these vulnerable communities without a commensurate improvement in the financial status of those affected populations. I mean, what can be accessed? What can be manipulated? By what strategies do we begin to close that gap? And it leads us to the question of, not only what are disparities, because disparities are not the issue of our diseases going up in terms of prevalence in the community. No, in fact, in our community here, many chronic diseases, the prevalence and the mortality associated with those are falling. I mean, in the last 10 years, we've had a 40% decline, for example, in coronary heart disease death in this county. We've had similar levels of success, for example, for attenuating HIV-related death. And same thing with stroke and other chronic illnesses. The only place in which it's really been going up very rapidly by 100% in this county over the last 10 years is Alzheimer's disease, which of course we're going to get to some of the issues associated with that in just a second. But I think the point is that it's not the issue of the sheer prevalence or the frequency with which diseases are occurring. It's the issue of the unfairness and the unjustness of it and the way those diseases are distributed and the impact they have on families and the impact they have on their social networks and their communities. And of course their ability themselves to be contributing members of society when you are not functional and you're struggling to find satisfaction with life. And remember that this issue plays out over the life course. It starts in utero, basically. It's called embedding, in which there are certain factors that begin to occur with greater frequency in populations that face adverse circumstances, and just progresses from there across the life course. I mean, gene-environment interaction is a continuous process. It's not something that, ooh, that's an event that's going to hurt me. It doesn't work that way. There isn't a watershed moment necessarily. I mean, there can be bad moments. We all have them in our lives. But this is a continuous process of interaction between human organisms and the environments that they're living in, whether it's in utero or not, extra-uteral, in terms of where you're going to experience it. So we have to understand that this culminates at the end of your life when you start reaching the end stages in the last, let's say, one-third of your life, in the disadvantages that are accumulated then in aging people. They experience these systematically at higher prevalence across their entire lifespan. And of course, when we start looking in our communities, we have to start looking at these issues from the standpoint, all right, well, that being the disease burden that these people are facing, then what are we going to do about it? That's one of the reasons, by the way, why we came forward in our group in the IOM, the work group on disparities, that we changed the name. We changed it from disparities to equity, to move away from the pathology of person blaming or subgroup blaming, or blaming women, for what they do, or blaming ethnic minorities specifically for what they do. Oh, it's their behavior that gets... We started thinking in terms of it's a question of fundamental fairness, and it goes to the social context and conditions and communities that create this propensity towards worse health. So that's where we have to aim. That's where Kaiser's aiming. They're trying to organize these communities, allowing people in those communities to do the job of identifying what the priority issues are and finding the best way forward so that those social determinants, as they are modified and as they increase the quality of life, will ultimately be able to improve the quality of life for aging people. Now, what do aging people really need and want? In my last 5 minutes, I'll proceed with that. They want control, just the same as everybody else. What does every teenager want? What every adult wants? They want coherence in their lives. They want to know if the situation around them that's affecting their immediate conditions of their existence and the quality of their lives can be better managed and managed by them to the greatest extent possible. If they have situations and they have health conditions that force them into dependency, because increasingly we've got more and more people who are poor in low-income communities who really are almost fully dependent on public system, and for example, Social Security as a primary source of income. They're paying very high rents. Federal standards do not calibrate according to areas across this country. So whether, if you're getting, as most people do, who are a minority background, for example, and even in other backgrounds, whether if you're white or Latino, African American, Asian, etc., you are going to receive an average of about $1,000 a month. If you are a low-income person and you've worked in those low-income jobs. Women in many of these groups are even less likely to get even close to that because of the fact they've been intermittent in the workforce. So they have to live on that. Well, in L.A., $1,000 doesn't pay your rent if you're living in a one-bedroom place. So how are you supposed to supply the other spectrum of needs that you're going to have? Food sufficiency, transportation, your medications, this whole range of things that we don't even think of, right? So when we start thinking about these issues, it all has to sort of draw into understanding the community, the human services, and the health services that were talked about by Winston, and how these can be better incorporated into an accessible system and network for sustainable aging in these communities. Latinos have a certain advantage in the sense that they come, 40% of the population is from abroad, and they've come here, and they actually come with superior health when they arrive, because they obviously come from a different society, different conditions, and even though they're poor in those societies, they seem to come here with a superior health behavioral profile, especially the smoking, drinking, drug abuse profile is much more favorable for them in terms of being much lower than it is in the United States. So that does really have a major impact on mortality, but it does not have a major impact on experiencing chronic diseases in later life. So people in the Latino population, when they hit 60, it doesn't matter if they're immigrant or U.S. born, they face the same situation that low-income people do in this country, because by that point the accumulation of experiences is going to lead them towards a situation of higher likelihood of having dysfunctions of various kinds, whether they're emotional, mental health, behavioral-related issues, and or in combination with chronic disease. So how we begin to make this stream of processes of care and community reinvigoration work together in a way that becomes accessible for people who do not have all the access in the world, and a way that is affordable, I think is something that we're going to have to really think through, and that you will have an opportunity at some point in the chain of processes of care and community well-being to make your contribution. So I'll stop right there, and we'll deal with this with questions and answers later.
After the panel has spoken, you'll be able to ask your question. So could we have Dr. Morrell?
Good morning, and thank you for having me here at All School Day. I'm so excited to be here, so excited to be talking to you today. I bring to you my perspective as a radiation oncologist, dealing with cancer patients every single day. My practice is actually located in Beverly Hills, but my patients do not come from Beverly Hills. My patients actually come from Inglewood, Downey, South Bay, Koreatown, and Sherman Oaks, as well as other places within the valley. As a radiation oncologist, I am part of a team that's dedicated to treating patients that have cancer. That team consists of surgeons, that team consists of medical oncologists that give chemo, nutritionists, social workers, patient navigators, and again, radiation oncologists such as myself, as well as family members and caregivers. And the list goes on. I see every day patients that have brain cancer, lung cancer, colorectal cancer, breast cancer, prostate cancer. In my practice, in the patients that I see young patients, I see 18-year-olds, 25, 35, 65, and on. In terms of radiation oncology, 2/3 of all cancer patients will receive radiation therapy. It's very important treatment, but not everybody is getting that treatment. So I'm at the forefront of what we call this war on cancer. What I'd like to do is give you some statistics. I don't want it to be depressing or sad, but I think the statistics speak volumes. According to the American Cancer Society, in 2013, 1.6 million people will be diagnosed with cancer. In 2013, it is estimated that over 580,000 people will actually die from the disease. So what are the more common or the most common cancers that are out there? For men, it's prostate cancer, lung cancer, and colorectal cancer. For women, it's breast cancer, lung cancer, and colorectal cancer. What are people dying from? Everything that I just mentioned. But the news is not all depressing. You probably have heard or read that the cancer mortality rate has actually decreased by 20% since its peak in 1991. That's outstanding. That's wonderful news. However, not every population, not every group of individuals are actually benefiting from that decrease. As a matter of fact, the gap in mortality between African Americans, Latinos, and Caucasians is actually wider now than it has been in 25 years. What brings me to the definition, basically, in terms of cancer health disparities, inequities, the definition that I use comes from the National Cancer Society, and I quote, or the National Cancer Institute, adverse differences in cancer incidence, so new cases, cancer prevalence, so all existing cases, cancer mortality, deaths, cancer survivorship, and burden of cancer or related health conditions that exist among specific populations in the U.S. So what does this mean? Cancer is now the leading cause of death in Hispanics. In 2005 through 2009, African American men had the overall highest incidence of cancer out of any group. Between 2005 and 2009, African American women had the second highest overall incidence of cancer out of any group. The mortality rate for African American men, if you look at all cancers combined, is 34% higher than any other group. In African American women, it's 17% higher than any other group. The medically underserved are more likely to be diagnosed with more advanced stage disease. What are the reasons for this? Why is this the case? And I think we've touched upon it already this morning. There's biological reasons, there's cultural reasons, there's environmental reasons, it's your socioeconomic status, it's where you live, it's lack of access to care, it's racism and discrimination, it's lack of insurance, and it's lack of awareness and knowledge. Who teaches you about health? Who teaches you about the risk factors for cancer? I actually had a discussion with my husband not the other day about colorectal cancer. He's 50 years old, and I asked him, I said, do you know what your risk factors are for colorectal cancer? Now, he's an engineer, and he prides himself on being educated, and he looked at me, oh, yeah, absolutely. Okay, tell me what they are. And do you know when you should start being screened? Well, actually, I don't know. And that's the kind of information that people are lacking. But that's the kind of information that we need to get out to the communities. A lot of money is spent on research, and we've looked into why the inequities exist and the disparities exist. We know what the reasons are. But for me and what I see the patients that are coming through my clinic every day that when I ask them, where did you get information about the prostate cancer that you were just diagnosed with? And they say to me, well, I got it from you. You gave me information. Well, what about before they got to me? What about the primary care physicians who talked to the patients about screening? I had a patient, a 70-year-old gentleman, 70. And I asked him, he had just been diagnosed with prostate cancer, and I said to him, have you ever had colorectal cancer screening? Have you ever had a colonoscopy? Have you ever had a flexible sigmoidoscopy? And he said, no, I haven't. And I looked at him and I said, but you're 70. Did you know that you should have started having that at age 50? And he said, no. So there's disparities in the risk factors, tobacco use, obesity, lack of exercise. We kind of touched upon it a little bit earlier as well. It does have to do with not having enough parks, not having enough green spaces, crime rates in certain areas where you don't feel comfortable exercising or going out for a walk. The tobacco industry targeting certain populations with their advertisement. Fast food restaurants, lack of grocery stores where you can actually go and get your fruits and vegetables and the things that you need to eat healthy. There's disparities in screening. We know that high rates of screening are associated with insurance, socioeconomic status, and your physician recommending the screening. So what do you do if your doctor doesn't tell you? How do you deal with some of the bias that exists in the medical field? That's part of what this is all about. There's disparities in treatment. As a radiation oncologist, I know that if you've been diagnosed with breast cancer and you choose to have breast conservation surgery, meaning you just have the lump removed, standard of care is to follow that with radiation therapy, and whether you need chemotherapy depends on your situation. But African American women, Latino women are not getting that care. They're not getting the appropriate adjuvant treatment. Colon cancer, 75% of Caucasians are more likely to get the adjuvant treatment they need when they're diagnosed with colon cancer. Lung cancer. African Americans are less likely to receive surgery for early stage disease, which we know is really important. So what are some of the other things that we're dealing with when we talk about these disparities or these inequities? Not only are we talking about the biological, but that accounts for only a very small percentage. But we're also talking about, the socioeconomic status, patient preferences, and physician risk aversion. Maybe your physician thinks that based on the color of your skin or whatever bias they may have or whatever comorbidities you may have, that maybe you're not a good candidate for surgery. So there's a lot of inherent differences in terms of, and biases and discrimination. That's all part of this. We need to focus on eliminating these disparities and these inequities when it comes to risk factors, cancer screening, cancer treatment, cancer survivorship. Minorities are more likely that under surveillance, after they have been treated for their cancer, to actually have a recurrence of their disease. We need to focus on getting the message out there, getting into the community, focus on health literacy, the information that's out there. If I say to you, you've just been diagnosed with infiltrating ductal carcinoma of the breast, we need to do breast conservation surgery, we're going to do a sentinel lymph node biopsy, and after that you may need to have chemotherapy based on an oncotype DX testing, and then you'll need to go for external beam radiation therapy. But that's what physicians say. That's what the medical community says. We need to use plain language. We know that when patients understand what their disease is about, when they have a full, complete understanding, they're more likely to get their appropriate treatment. Instead of saying you have all those things, you should say you have a mass that's been found in your breast. You need to have surgery. We're going to surgically remove it or cut it out, and after that you will be fine. You may need drugs that will course throughout your entire body, killing whatever cancer cells may be left behind. And then we're going to have you be treated with radiation therapy that's going to offer you even more protection. Plain language. As social workers, you are an absolute important part of this. Most cancer patients are treated at community cancer centers, not necessarily at the large institutions, the large universities. What that means, though, is that these small cancer centers, these community-based centers, they don't have social workers. They don't necessarily have patient navigators. But it's absolutely important. Everything from the psychosocial support. Marriages are falling apart. Children are not getting the counseling that they need. Financial situations. Patients are losing their jobs. They don't know how they're going to support their family members when they have been the primary breadwinner, and now they've had all this cancer treatment and they can't function. So there's a lot that we need to do, and that's why I think this is so exciting that we're talking about this today, because I do think that we're going to make some inroads. We have already. We're going to make some progress. And by being here today, again, it's just information that's getting out there, and we can actually figure this out to try and decrease these disparities and inequities. Thank you.
Good morning. I think it's still good morning, right? I know it feels like it's going to be lunchtime soon, but my name's Hortensia Amaro. I'm joined the School of Social Work as a faculty member this semester, actually last semester, and I'm delighted to get a chance to speak with all of you, and hopefully through my course here to have the chance to interact with you in the classroom, through independent studies, and just through general conversations. So thank you for inviting me. So I wanted to first say a couple of comments about Dr. Wong's talk, because I thought that he hit on so many factors that are really important. He really covered a lot of ground. But I wanted to go back to the issue of social determinants of health, which, you know, as I'm a psychologist, I'm trained as a psychologist, and my work has also been in public health for the last 33 years. And I think in both psychology, like in social work, and even in public health, for most of the last, 50 years of work that's been generated in those areas, if not longer, the focus has often been on individual behaviors and the role that lifestyle behaviors, for example, or individual risk factors. And we know that we're now starting to understand that really things outside of the individual have a significant impact in determining those individual behaviors, as well as the life conditions that impact health. I think one of the students who asked a question earlier really highlighted that. And of course, Dr. Wong spoke about that as well. So in public health, so it's often it takes a lot of effort for us to turn our gaze away from the specific clinical encounter or individual factors to look at what is happening in that community, what are the social policies, et cetera, that really impact that person that you're seeing in a real fundamental way that almost defines the pathways, the choices or liabilities that they are exposed to. So there's this analogy that I always like to mention because I think it makes it very clear. So in a village, a doctor goes and is asked to help because there are all these people coming down the river who are drowning. And all these people are trying to help the people, pull the people out of the river. But there are too many. They can't pull them all out. So many of them drown. And then a community health worker comes along and says, let's go upstream. What's going on that so many people are drowning? And let's find out what the source of that is and address that so that we can prevent and reduce the number of people who are coming downstream drowning. And that's really what this social determinants perspective highlights for us, that we really need to go upstream and look at the larger social factors. And of course, social work has been doing that for a long time. You have focused a lot on community factors. So this is to emphasize the importance of that and the strengthening of that gaze upstream. We know then that our interventions have to be not only at the individual level, but also at the community level. And at the community level in terms of improving the living conditions. We know that where we each live, where we each work, where we each play, where we each pray, really defines the trajectories of our health in very fundamental ways. And so what does that mean? That means that we need to turn our gaze toward interventions that address and improve those conditions. Some people are referring to this as creating communities of opportunity. And I can answer questions about that if you're interested. So that doesn't mean we don't need the clinical programs, we don't need access to healthcare, we do. But we now know that beyond medical care or clinical care that before people come in, we need to create communities that are healthy and that create opportunity and that allow children and families to really develop their potential. So, and that's what I came to USC to do, and I'm in the process of formulating that and really looking forward to it. I did want to be responsive to what I was asked to speak about, which is the work I did in Boston, and I'll try to mention how that really led me to my interest now in an approach that's broader than the clinical. So for the last 33 years or so in Boston, I worked very closely with the city and state health departments and community agencies to improve systems of care in especially in substance abuse treatment and HIV prevention. And so that ended up being an incredibly fruitful approach to work so closely with the health departments and community agencies in developing and founding a number of substance abuse treatment programs for women and men, outpatient as well as residential. I do want to tell you about one study we conducted that I think really highlights something critical that I know you're learning about in your classrooms and that you're working on probably in your clinical work. So we know that both clinical, our clinical experience, but also plenty of research, and we certainly saw this in the years that we were doing substance abuse treatment with women and men in Boston and the programs that I had started and elsewhere, that when people come in for substance abuse treatment, that is not their only problem. In fact, there are usually a host of complex problems, including mental health, history of abuse. In the women and men we saw usually long histories of chronic abuse stemming from childhood onward. And then the resulting mental health problems of post-traumatic stress disorder, depression, anxiety disorders especially, but as well as others. At the same time, we observed that there really was a lack of system responsiveness to this reality, that patients and clients had to go to one silo, the mental health system, for those services, to substance abuse, siloed in another system of care, and then to maybe domestic violence shelters and services in yet another system of care. They were also dealing with child protective services, etc., homeless services, etc. So it was very disjointed. So we decided to, and clients clearly told us how they experienced that. So we decided to conduct a study. This was the Boston site for a 9-site study that was conducted nationally, funded by the Substance Abuse Mental Health Services Administration. And the study was called the Women's Co-occurring Disorders and Violence Study. And I'll tell you specifically what we found in Boston. So we developed a way of integrating trauma, addiction, and mental health treatment at the clinical level, developed treatment protocols, treatment manuals, etc., trained the staff. Lots of training had to go on and cross-training. We also developed interventions at the system level with roundtables of service providers across the city from all these silos that I mentioned to also provide training to make better connections for client care. And of course, memorandum of agreement on how we were going to take care of patients together. We chose intervention sites and services as usual sites that were providing standard services without integrated care. And basically, we followed those patients, provided the intervention, followed them at various points in time up to 12 months. And I'm getting the signs, so I'm going to be really brief and now go into the findings. Basically, we found that the women who received this integrated care in a gender and culturally tailored way did much better at 12 months, which is the only follow-up that we had, 6-month and 12-month follow-up. I would have liked to follow them longer, but that was the last measurement point. we found that they had higher rates of drug use abstention, lower rates of mental health and trauma symptomatology, and lower rates of HIV risk behaviors compared to those in services as usual. And that this benefit was present for women of all racial and ethnic groups. So we tested for interactions by race and ethnicity. So, you know, this provided this now intervention and model approach. It's called the Boston Consortium Model. It's listed in the National Registry of Evidence-Based Models, and I'd be happy to give you more information. But it did highlight the importance and the difference that integrated care could make. The big challenge we face, of course, is how to take a model like this and make it real under something like healthcare reform. It requires a significant amount of staff training and supervision and cross-training, which is really where we're going now with a care team that's interdisciplinary. And I think you're all getting training on that as well. So tying this back to my initial comments about context, one of my continuous frustrations in developing treatment programs and protocols and looking to see whether they work is that people in outpatient were still living in the communities that had placed them at risk to begin with, often in the same home situations. People who came to residential, and we invested all this time and they invested all this time, were returning to these communities that had a lot of liability. And so it's for that reason that I really now want to turn my gaze in my work a little bit more upstream and to the role and the contributions that we could make in creating and fostering communities of opportunity. Thank you.
Okay, that's just wonderful. Thank you so much. Now, we're opening the floor for questions, so please feel free to get up, and this is your chance, your last chance, so get up and do your thing. Okay.
Hello.
Okay. Professor Mary Alice.
Mary Alice Jordan Marsh. I'm a nurse psychologist in the School of Social Work, and I was so struck with Dr. Morrell's comments about plain language. One of the things that social work is so characterized by is a recognition that bankers have assets and poor people have needs. And I think the revolution that is possible for all of us right now is the playing field is a bit leveled with technology and access to the internet. And one of the assets that is specific to African Americans in America and Latinos is many of them have a smartphone. And I wonder, as you three think about the programs that you're involved in, to what extent we are moving to an interaction with clients and communities where we ask that client to turn that tape recorder on that is on that smartphone and tape what she just said and never let a client leave without bookmarking a link that they can go back to later on.
Okay, yeah, wow.
Absolutely. That is something that I'm actually very much interested in. The digital divide is incredible. The patients that do have, the people that I meet that do have smartphones, it's invaluable. But then I also come across many, many patients, especially elderly patients that don't have smartphones, that don't have internet access. But that is where a lot of the information is. And so we do need to figure out how to conquer the digital divide. What I would like to see for every patient that comes through my door is the ability to, when they're diagnosed, to have their information, everything, including their medical history, put onto a device with the information about their cancer, about how it's staged, how it's treated, what type of procedures are needed, what type of imaging is needed, so that they can take that with them when they walk out and they have it with them. not only would they have it for themselves, but then they could pass that device to their family members, to those that are going to be caring for them, so that they can also have that information. So absolutely, I think technology is amazing. It's definitely moving in a direction where our smartphones are going to be able to basically diagnose different types of illnesses. So I really do think that there will be a big push, and I know that there have already been research projects that have looked into trying to tackle this issue in terms of technology and the digital divide.
Well, thank you.
Hi.
Thank you. The next person. Oh,
Hello.
sorry. We'll come to you in a moment. Sorry.
I would like to address all of you in thinking upstream. My question is more to thinking about how to create spaces that are more inclusive to people of lower socioeconomic classes. If you think about other places like Irvine, who did a master plan, who spreads out people who have lower incomes into places where people who have higher incomes. But what I'm afraid of is white flight. I'm afraid of people being scared of people who have my skin complexion. I'm afraid of doctors in lower income areas who are not seen by a board of review or have continuous education to bring knowledge about cancer, to bring knowledge about different illnesses. So basically what my question is to address is, what are your ideas as far as evidence-based practices, and how can we implement them on a macro level to all the lower income areas in America?
Okay. Oh, wow.
Big question.
All right. Which of the panel or all three would like to answer?
I think that's I'll just start. I'll just say that that's, of course, a macro question that we look at from multiple points of view. I mean, just the issue of training alone and being certain that the various disciplinary groups and professional specialists that are doing this work have had adequate training. Certainly, for example, in aging, it's not happening. It's not there. They haven't had adequate training. Just that's a basic issue and an expensive issue to remediate for those already in practice, but we certainly have to look at it from the standpoint of where we are now in our development of people going out into the field and being certain that they have that capacity. And I think that's start point number one. Secondly, of course, is the whole question of how do you make these things tailored to be culturally competent. And there's always been the war of should we make it idiosyncratically targeted for an ethnic special group, or should we make it targeted overall? Now, frankly, this is a non-winnable contest, because the provider system and the way systems are developed and evidence-based practices are not ever going to be able to just develop one fragment silo for this ethnic group and one fragment silo for the other, because the system is standardized in billing, in diagnostic categories, etc. So this requires micro-tailoring and developing approaches that, while at one point cross-cut, because you have to have the skills for everyone, are also developed in specific terms for populations that you're seeing routinely in practice, so that you can anchor, the interpretation of what you're doing in communication processes. So I think all of these are issues that go to that question. And the third thing that I think is critical in this is the fact that more and more what we're seeing is mixed neighborhoods with highly diverse patient populations that are coming in, or even in public health outreach this is the case. We cannot continue the practice, and I think it's becoming undesirable to continue the practice of, frankly, stratifying all of our interventions around ethnicity. We can't do that very, very successfully anymore. And quite frankly, what it has shown, I've been in some of these interventions with youth that were developed for African American kids, and then we had Latino kids that were in there because they were in there in those same classrooms where these interventions took place. They all benefited. They all benefited from an Afrocentric model. This wasn't done in New Jersey because it was well done. And because, frankly, the overlap in the issues that concern families and kids and the issues around control over their own lives are very similar when you're powerless in these low-income communities. So, I think we really have to rethink this issue and how we approach it under affordable care, because that's not the way affordable care is going to go. It's going to go through primary care, and then it's going to be, splayed out over questions about, is this a follow-through process of care issue, or do we need to develop more intensive community-based interventions to support less cases so we lower the incidence of these diseases? It's going to follow a public health and care model. So that's going to have to adjust itself to the issues of inequality and issues of cultural difference in a way that works for everyone. And this is a 20-year train ride.
Okay, thank you, thank you. Well, I think Dr. Vega has given us a full account, and we have got quite a number of people here waiting, so if we could just move on.
First of all, I'd just like to say that I know it looks like my colleague and I are speaking a lot, but we're actually representing the hundreds and hundreds of VAC students who are participating virtually right now, which is why we're constantly at the microphone. But I just wanted to share, Nicole Dainstrad had a question for Rosalyn. Europe has different methods for treating cancer. Many family members and friends have traveled there to be treated since the U.S. doesn't allow non-pharmaceutical methods of treatment. How much does the pharmaceutical industry control as to what treatment to provide, as some alternative treatment may reduce their income?
I think it does absolutely have an influence. The pharmaceutical companies and the companies that are involved in getting some of these drugs out in the treatment of cancer do have a significant influence on that. The cost is astronomical for patients who want to be on certain drugs. It's just incredible. For instance, with drugs prior to going to generic, I mean, $400, $800 for 30 pills. I think alternative medicine certainly absolutely has a place in terms of treatment of cancer, and I'd like to absolutely see that more so in the treatment.
Thank you. Next, please.
Hi, my name is Donald Wilson. I'm from the OCAC. Dr. Amaro, as we are aware of the high cost of health care when any individual, regardless of socioeconomic status, becomes sick or ill, do you see any movement from the medical profession to move up that stream and speak about and address prevention wellness rather than illness?
Well, I think that there's a move toward more interest in prevention. I'm not sure, how much traction it's actually going to get. We're going to see. But I would say that in terms of really moving upstream, it's not going to happen in the doctor's office. It's going to happen outside of the doctor's office way before. So we're talking about community development. We're talking about what the previous gentleman asked about, how do we create communities? So this move toward looking at how to create what's called communities of opportunity, which really requires the combination of a public health approach in combination with housing, with transportation, with economic development in communities. So it's going to require reinvestment in those communities that are not now communities of opportunity. And, this isn't the first time that people have considered this. There have been a number of, quote, social experiments or approaches looking at this issue. The moving to opportunity endeavor was one. Other approaches that are more focused on, no, we're not going to move people elsewhere, but rather we're going to invest in improving those opportunities. So there is a lot of controversy and discussion about which are best approaches, but I think more focus on that is really important. And I think regarding the point that Dr. Vega made about specific interventions for specific groups, we know in public health that we need both general public health approaches that impact everybody, whether it's about cancer prevention or anything else, but that generally those kind of campaigns and efforts that are generic, they do tend to show improvements in everybody, but they do not show improvements in decreasing health disparities. So that you need a generic approach to help everybody move, along to the outcome that you're seeking for that specific campaign, but then you need to go kind of deeper and more specifically into certain communities that have higher level risks to make sure that their disproportionate risk is also being addressed.
All right. Thank you, Professor Amaro.
I'm sorry, I'd like to make a comment about that. And I agree with you. It's not going to be in the doctor's office. I think the community needs to be mobilized. We need to really understand the differences, the cultural differences. Utilizing, for instance, in the African American community, barbershops, beauty salons. We know that those efforts work. Using promotores absolutely works. We need to get the community where people who are trusted in that community to get out there and get the word out and do the teaching. That's really important. If you see somebody that looks like you talking to you about certain issues, there's that trust that's there. And that's something that's really important.
All right, thank
Now,
you.
I'd like to just insert one line. One line. The Affordable Care Act primary goal is improving population health.
Right.
How we get there?
Yeah.
Okay, that's the goal.
Okay, well, thank you so much. Now, I think what we're going to try and do, and just bear with me a moment, is that if we could have your questions to be shorter, and if we could have your answers to be shorter, because we're actually looking at a time scale here, and other people have other things this afternoon. So let's just try, and I want to accommodate everyone so that that's a standing. So if you could just make your question short, that would accommodate you.
This question is for Dr. Merrill from Stephanie Doss, a VAC student. She's wondering, do you feel that the Affordable Care Act will improve access to cancer treatment to underserved groups, and will there be some different challenges with this new law in regards to cancer treatment?
Yeah, it definitely will. It'll improve preventive services. So I do think that will be a wonderful thing, because now there will be people that will have access to those services. I think, however, as physicians, we may not have figured out yet how we're going to handle the number of people that are now going to have insurance. I think that's going to be a challenge. So much falls onto the primary care physician's shoulders, and I think that we're still kind of trying to figure that out, how this is all going to work. Everything that we've talked about this morning plays into all of these patients getting insurance and trying to figure out how are they going to navigate the system, and how are we going to get them to their appropriate providers in a timely fashion. So I think we're still kind of like getting ready for it, but I think that the Affordable Care Act is going to certainly allow a lot more patients to have access to these preventative services.
Okay, thank you. If some questions are similar, you don't have to ask them. In the case of time, okay, all right. Next person.
She's getting more strict as we go along.
I know, right? Hi, my name is Ashira Windsor, and I'm from the VAC, and I rode up with the San Diego campus students. I live in San Diego. And my question is, you did somewhat answer it, but I hope that this is not a repeat. I wanted to, as social workers, we are taught to be culturally sensitive and to be aware of that when dealing with our clients. I wanted to know in what aspect are doctors trained in that way, and what are you doing, I think, to fill the gaps for where, because I know as African American, we are not that trusting of bureaucracies or systems, so I just wanted to know, are you trained to recognize that, and what would you do as a stopgap measure? Would you send them to a social worker, or, and I'm shortening this, okay, and that's it.
A short answer, please. Thank you.
The answer to your question is no. We are not trained. No. No, we are not.
Okay.
Yeah, actually, I'll tell you, In New Jersey, you can't be relicensed without taking a cultural competency class, but of course that's I call a car wash cultural competency experience. You know, you go in for an hour and you have Bill Vega talking to you about an hour about the need for it. You can't do more than that. You're not going to train them in cultural competence in 1 hour, but you satisfied, you know, certain requirements. And frankly, that takes place across the board. You really don't have a commitment to consistent, you know, outcome-based approaches to cultural competence training in healthcare providers. I think Kaiser actually they're the pioneers in this, in developing the approaches, but unfortunately they're not consistently implemented, and even though it's called for on the ACA, you know, it's not being done yet. I mean, we're waiting to see the seriousness with which they take the initiative in this.
Okay, thank you. Next, please, short one.
Hi, my name is Max Molina, UPC campus, and the co-chair for the Men in Social Work Caucus, and my question is about awareness, and so as the Men in Social Work Caucus, we did the second year in a row Movember campaign, you know, to increase awareness for men's cancers and men's health. And so what advice can you give us in terms of bringing that kind of awareness to our communities, you know, as well as just whether it's like breast cancer or Movember for men, but how can we also bring that kind of awareness to our communities?
I think in terms of having people in the community trained to deliver that message is really important. Again, getting back to the issue of having the individual people who reside in that community to be trained in some of these healthcare issues, to be trained in some of this cancer awareness, to get the message out there. It's absolutely critical that we start there, that's where it starts, and actually training individuals to go out using plain language, like I mentioned before, using different methods, because we're all different in terms of how we learn. Some people learn verbal, some are visual learners, and we need different methods and ways of getting that information out there. And for, you know, we all hear about breast cancer and it's the pink ribbon and things like that, but, you know, in terms of men's health, that's really important, and we have to understand men and some of their behaviors and how to get that information out there in terms of risk factors.
Okay, thank you. Can nobody else join the line? I've noticed that other people are joining the line. Please don't join the line. Thank you. Okay. Am I missing somebody? Yes, okay.
Yes.
All right. A short one from the top.
From Bianca Reed, who's a VAC student, what accounts for the increase in gap in mortality rates for cancer amongst ethnic groups in the last 25 years?
A very short answer, thank you.
Everything that I mentioned in my talk. Minorities are, like I mentioned before, are diagnosed with more advanced disease. Some of it's biological, and we're looking into that. Triple negative breast cancers, where you're estrogen receptor negative, progesterone receptor negative, HER2 new negative, you're not able to get the types of treatment that the less aggressive cancers are able to receive. So I kind of lost my train of thought, but so yeah.
Okay.
Short answer.
Well, we've got so many people to cover, and what I'm trying to do. I don't wish to be, you know, so dictatorial. It's really not in my nature. But we need to just cover all these people that are standing, so that they feel as if they've contributed because they've got a question. So, if we can just say them quickly, if some of them is coincided with something that's already said, then we understand that you don't have to say it. Okay, all right. Okay.
Hi, my name's Chelsea. I attend the Orange County campus. My question's directed to all of you, but Dr. Vega, you mentioned it briefly. I'm wondering about your concerns or thoughts on Alzheimer's disease, as it doesn't seem to discriminate and is currently the 6th leading cause of death in our country and the only cause of death among the top 10 that cannot be prevented or cured or even slowed.
What's the question?
Is there a question there? You're absolutely correct. Is there a question there?
Yeah, your thoughts or concerns, just
Well,
addressing
yeah,
it.
of course. This is a worldwide phenomenon, and we're going to have 72 million people over 65 in 15 years in the United States, and you've seen these startling prevalence rate estimates that they give for the increase in dementia-related deaths, especially Alzheimer's-related death. I can tell you that right now there's an enormously interesting leads, but we still don't have a confirmed causal process for Alzheimer's disease. We're getting better at screening and detecting, but in terms of the causal mechanisms, we don't have it yet, which means we don't really have an open road to medications that can really confront this and really attenuate the situation early enough in the course of the disease so that people won't have to experience the later course of it or to avoid it altogether. So we're still in a very, very tough area in terms of making that gap complete, of bridging over into actually having confirmed mechanisms that we can identify that we have medications that can address those to stop this from occurring and progressing, and for those who already have onset.
Okay, thank you. Next person.
Hi, my name's Sarah. I'm from the UPC campus. I'm just interested in what your response is to the popular opinion that the implementation of the healthcare reform is going to result in a decrease in overall health quality, or healthcare quality. A decrease? Does that make sense?
Did you
okay.
Did she say a decrease?
Yeah, she's saying it will actually possibly decrease healthcare quality. Because of unforeseen, untold consequences. Yeah, I think that's I'll just speculate on that because nobody knows. I mean, that's an open hypothesis, In fact, this gives me an opportunity to read one line I was going to read during my presentation, didn't get it, because it's a perfect exemplification of it. This is Don Berwick, who actually headed the implementation of healthcare reform for the first years after it was introduced. This was his comment. He said, "Every system is perfectly designed to achieve exactly the results it gets." And I think that means that we have a lot of cooks that are stirring the pot, and they have very different intentions. And the end result is going to be what we've got in 20 years of who stirred the pot and added more ingredients from their own political persuasion, ideology, or for their own ends. And that includes interest groups such as ourselves. The ability to make a change and ability to guide that process is going to be intermittent, and it's going to fluctuate. But I think that clearly, the end product is going to reflect the political intentions and the will to get to the end point that was designed at the first place, which is population health improvement.
Thank you. Thank you. Thank you. Could we have the person on the balcony?
Yes. Hi, my name's Nicole. My question is, in your professional experience, what sort of health disparities are faced by transgender individuals trying to receive adequate health care? How are healthcare providers prepared to provide equal, safe, and adequate services, and/or what improvement should be made to be more inclusive of the transgender population?
Well, overall, I mean, we know that LGBT populations, and particularly transgender, face a whole host of obstacles to healthcare, to discrimination, to violence directed at them, and stigma, which really complicates, access as well as quality of care. I don't think that physicians and even mental health providers are trained sufficiently in working with GLBTs, especially the transgendered community. We know mental health problems are huge, of course, stemming from, the stigma, access for the medical treatment. We know, so just generally, I think these are huge, and clearly they need to be addressed. But perhaps the others can be more specific.
No, I would just add to that that I think the training issue again comes forward, that clearly our medical specialists today really have no understanding of the fundamentals here, unless they've received some kind of special exposure because they've had patients, et cetera, then they begin to become aware of it. But my oldest child is transgender, and I've seen this. His name's Gabriel, and now it's a she, Gabriel. And this has been 30 years old, and 10 years of this, of going through this process, of course, with all the special issues associated with appropriate medical care and transition and all of these other issues. So it's been horrifying, I can tell you that, especially the lack of understanding, the lack of receptivity, the harshness of the medical profession and its reaction to it. I mean, there's so much stigma associated with it. And it's really been a very, very difficult experience that you really have to brace yourself for, because it does not stop. And the difficulties that marginality, socially, just reinforce the marginality that you feel in the medical context.
And you just emphasized the point again that as medical students, we are not trained. We are not exposed, we are not trained. So when we get out and we start practicing medicine, when you come across a patient, and I mean that can sometimes be your first time where you're dealing with certain issues. So again, I mean, we need to get into the medical schools and start training our doctors. I mean, this is a really important issue, and we're not addressing it right now. You can get CME credit or CE credit afterwards when you're out of training, going for relicensure, but in the medical schools is where it needs to start.
Thank you.
On the balcony again.
From VAC student Jamie Sepulveda. What ideas or solutions do you offer to people that will not benefit from the new Healthcare Act, such as undocumented persons? Is there a safety net in place for them?
Professor Amaro.
Well, of course, a safety net implies that there's some cohesiveness to it. I think what we have is dock-in-the-box operations around town, all over the place, especially in low-income areas where people pay out of pocket. And we know that people do use those kinds of operations, and we know that they go to health fairs. And we hold one here in the old LA sports arena, right? And we get 10,000 people that show up for that, and they're waiting outside the doors when we close them because their need is unmet. And among those needs, number one is usually dental care, of all things, because there's nowhere to get that, and even public pay doesn't pay for that for the most part. So, when you have public pay insurance, so we have a real problem trying to knit something together. I have to say, I mean, obviously there are other methods too that some people do get into care as charity care, clearly, and some people do manage to find alternative providers in their communities that are providing for them. And some people, especially in this area, go across the border to get their care. So it's there's a number of options that people can take at the personal level, but none of them are satisfactory or represent a coordinated system of care.
Okay. I agree with your comment, Bill, and just wanted to add that it's not a system of care, it's not a safety net, because the places where people will go are so spotty. But there are some states, like Massachusetts, that have chosen to spend some of their own dollars in covering some people who don't meet the criteria for health care reform, such as the undocumented. It's not going to cover everybody, it's not going to cover everything for that population, but at least there's some effort there. So we'll see what happens with immigration reform, but Bill was telling me earlier that even the plans for that don't include qualification for health care coverage.
Okay, thank you. Next person.
Hello, my name is Rigo Estrada, UPC. My question, you brought it up a little bit, but from your experience and interactions with people, peers from your own profession, do they want the cultural sensitivity trainings? Do they feel a necessity for them, or is this something that they wish not to get involved with? Does that make sense?
You mean the patients themselves, the individuals?
No, the doctors, the
doctors.
professionals, your peers.
Other professionals, do they want I think some of them do. I think some of them don't really think it's necessary or think it's important. But Some of them do. I think there needs to be a bigger push in terms of getting more minorities to go into the medical profession. I think that would also be key as well. But there are some professionals, healthcare professionals, that do understand how important that is, and that they need to have that type of training to effectively communicate to their patients, because their patients are not going to get the appropriate treatment. They're not going to go for the test. They're not going to do the things that the doctors or the other healthcare professionals are telling them to do, because the communication is not there. There's a breakdown in communication. So I think, yeah, those that are really wanting to make a change and see the need for a change should actually be very concerned about having that type of training.
Okay, thank you. Okay, sorry.
My name is Natasha. I'm a part-time here at the UPC. Kind of semi-touching on that, but a little of an expansion is about the upstream issues, as we're referring to, and the problems, if there is a problem within the medical profession itself, in terms of the elitism and the lack of diversity, in terms of who's on boards and who's making, the decisions for the profession and for the medical schools, that hierarchy and elitism affecting that issue as well.
Mm-hmm. Yeah, it is. And I'll give you a perfect example. Obviously, you can see I'm passionate about this subject. It's an important subject. My national organization, which is called ASTRO, we have submitted 3 times for our national meeting an educational session on health disparities, or cancer health disparities, and how healthcare reform is going to impact this. And it has been rejected. So 3 times. So there are people higher up in the hierarchy and sitting on boards who are making decisions that this type of, or these type of issues are not important.
Okay, thank you.
I'll make this quick. My name is Barry. I'm a VAC student, and this question is going to kind of pang me a little bit to ask, I'm sure everyone here as well. One of the things that I kind of feel is my job as a social worker and a social work student is to kind of advocate for the vulnerable populations. And one of the things I hear a lot is people feeling like low-income individuals that don't need to pay for health insurance because they don't have health insurance, can't afford it, are going to the emergency rooms for, maybe a common cold or something that's not an emergency. And what I'm wondering, I'm sure you guys have heard this also, what do you feel is a good retort for that? What is a good reaction to give them?
Now read the research literature. This is not true.
They won't do that. They'll take the time to listen, but not the time to go out and pursue it.
Well, of course, that is a popular assumption, especially with undocumented immigrants, that they're overusing emergency rooms. Hector Gonzalez just published a paper on that about 2 months ago, showing from national data that this is not true, and it wasn't the first time that this has been shown. It's like the myth of the immigrants are all coming over as criminals and they're all in jail, and when you look at the actual data, it's minuscule percentage compared to the U.S.-born Latinos, and rates. I mean, there's just a stigma again, on immigrants because they are attributed, are projected to have, every malady and every bad behavior and every bad outcome, which is untrue. In fact, they're a fairly healthy population overall, healthier than the U.S. population. They live longer than the U.S. population by a couple of years. So that's hardly the case. So we know that there's literature out there, there's documentation the other way. I think disseminating it effectively, it depends on who you're trying to reach. But I think it's something that the press has certainly not made a major issue of in getting it out. But I think it's a critical issue to be disseminated, especially if we're trying to move affordable care forward and getting acceptance of immigrants being covered, especially undocumented.
Okay. Wow. I'm sure you'll agree that we've had a wonderful morning. Can we have a round of applause again for the panel? For Dean Flynn for continual support. Another round of applause. And also for the committee, if they could stand so we could give them a round of applause. Okay, and please don't forget that we've got 2 of our professors here, so you can always continue the dialogue. Okay, all right. I'd like to turn the podium over to Kristen. Okay, thanks.
Just want to say thank you to everyone that made it out. Really appreciate it. Hope you enjoyed this year's topic. To continue the discussion, Student Org is going to be presenting a panel of documentaries titled Broken Equality in the World of Health. We're going to be showcasing 3 documentaries, one called The Natural Causes, Is Inequality Making Us Sick in Sickness and in Wealth? Number 2, Under Pressure, Causes and Consequences of Hospital Overcrowding. And number 3, Weapons of Mind Destruction, The Journey of Recovery for Soldiers Returning from Iraq and Afghanistan. So we're going to be having discussions on this once the videos are showcased, and we welcome everyone to attend. It's going to be in MRF Hamovich from 1 to 3 p.m. And also, you all got an email survey sent to you about All School Day. It's an evaluation. If you can please fill that out, you are entered into a raffle for $25 if you do get that. So just good luck with that, and I'm glad that you all made it out. And lunch is going to be provided after this, so you can go ahead and grab that and be on your way. So once again, thank you very much.